Hello, I'm Michael Hainsworth. Thank goodness for the leap year. On February 29th, Federal Health Minister Mark Holland joined the NDP's Don Davies to announce a Pharmacare plan has been hammered out. One day before the deadline that could have seen the NDP walk away from its deal to prop up the Liberal government. Phase 1 is being described as a proof of concept and a pilot to be evaluated. Will this pilot even get off the ground? Meet Fred Horne. He is a Canadian health policy consultant at 360 Public Affairs, an Institute Senior Fellow, and a former Alberta health minister. Also, former Minister of Health, Dr. Jane Philpott. She held a portfolio at the federal level under the Trudeau government from 2015 to 2017. And from the CD Howe Institute, Senior Policy Analyst and the leader of the Institute's Health Policy Council and Research Initiative, Rosalie Wyonch. Thank you all for joining us.
Thanks for having us.
Rosalie, set the scene for us. This is described as a national program, but the framework requires agreement with the provinces. Is this how we dance around the reality that medical care is a provincial purview?
It seems like that's the way forward, or that's what the federal government has decided to do. I think it's also a way to potentially avoid having to shoulder the full cost of a program. If the federal government were to run a program completely on its own, then it would also likely have to shoulder the vast majority of the costs. So I see this as maybe an imperfect compromise to protect the long-term federal finances, but also to manage the constitutional jurisdictional issues so that, the federal government isn't stepping on the province's toes, and hopefully there can be more cooperation.
Fred, I know you spend your time on Vancouver Island these days, but what the heck's going on in Alberta? It's already stated it wants nothing to do with Pharmacare and wants the cash instead. Will it get it?
I think that's a good question. The evolution of this program that's recently announced is quite different from what we've been used to in years past. So, this is coming forward in the absence of a broad pan-Canadian consensus among the provinces, and it's going to be enacted through bilateral arrangements with each jurisdiction. So, I was a little surprised before the legislation to hear any province kind of rejecting it out of hand before the details had been released. I think it will come down to in the case of provinces that are questioning it, a number of things, including the specific arrangements they can get with the federal government, but some other things like what happens to private payer coverage as well.
Fred pointed out, Jane, that it was rejected out of hand even before we really knew much about it. We don't even really know much about it, even though it's announced. Ontario's health minister says she still has a lot more questions about the plan, and Sylvia Jones even suggested that Ontario already has more than what the Pharmacare proposal offers.
So you're right. This is a bit of a roundabout, odd way that this is happening. And to Fred's earlier point, it hasn't followed the pattern that we've seen with other big national programs. In fact, Medicare in the first place and hospital insurance going back decades now. So I would say we absolutely need national/federal leadership on something like this for it to be successful in the long run. I think a national program is ideal. And I think if the program is successful in some places, hopefully there'll be a public outcry that will encourage others to get on board. In an ideal world, it would have been great if the health ministers across the country, provinces, territories, and the feds could have gotten together and agreed on this and kind of come out together jointly with their enthusiasm for a program that they'd agreed upon together. That hasn't happened. But it's not completely unusual for Canada to do things piece by piece. In fact, as I said, back in the initial Medical Care Act, the initial Hospital Insurance Act, they were started in a province, eventually spread to the rest of the country, and maybe we'll see that happen. Slightly different arrangement this time.
Rosalie, it sounds like we just aren't taking the necessary approach to ensure that this is a program that goes from pilot to nationwide on all aspects of Pharmacare. Does the Institute really even have a sense as to whether or not this is going to be a thing as the NDP had envisioned it?
Well, I guess initially what we would have expected from the NDP was, and what they were pushing for was a national, universal, comprehensive program. And this currently is not national. It is going to attempt to be universal, but if it doesn't cover all the provinces, we might not satisfy that concern. And it certainly is not comprehensive. That's partly that we need to start somewhere, and there simply isn't enough room in the budget to cover all treatments. As well, we need to decide what's in and what's out, and the legislation makes clear how the formulary development process will go. So I would say this was a first step in the direction of potentially what the NDP was shooting for. However, the involvement from provinces, making it not technically a national program, and also just the timelines and fiscal constraints are really limiting what has been announced in terms of what this Pharmacare plan will be. And it will really take time and the agreements with the provinces before this can actually roll out. So there's a good chance that it's going to take quite a lot longer to, if it is going to reach the vision of a national universal program, it's going to take quite some time. And it's not likely to happen before the next election.
Fred, you've expressed concerns about how implementing such a program would affect individuals with private drug coverage. What's your concern?
We know that a large number of Canadians have access to private or employer-sponsored drug plans through their workplaces and some through other avenues as well. And we also know that that comes at a cost that the public system currently doesn't have to pay. The legislation's been proposed as first dollar single payer coverage, very specific to that point. So from the point of view of a provincial health minister and a government trying to deliver healthcare that includes many other priorities, one glaring example today is access to primary care. And, depending on the figures you look at, and this is something that's actually, the access to physicians is something that's actually guaranteed by the Canada Health Act. We're looking at a situation where, upwards of 20% of Canadians don't have regular access to a family physician. So what this adds up to, from the provincial perspective, I think, is opportunity cost. And do we really need a single payer Pharmacare system that has the potential to cut out private payers who are already covering some of these medications and other medications? In some cases, they're for new medications that are bringing them to patients faster than provincial drug programs. Or do we really need to be looking at a model that addresses the specific issue that we're trying to deal with? And I think there is consensus that issue is the affordability of drug coverage for Canadians, both the majority that have access to either a public or an employer plan and the ones that don't. I think there's still some discussion to be had as to whether this particular solution and this philosophy of a universal single payer approach is actually going to be worth it. And, what is the opportunity cost? What is the expense going to be if we're cutting out private payers who are already delivering that coverage today? The other thing I'll say is, that if the issue of affordability is huge in and of itself when it comes to access to medication, and you only have to listen to, the parent of a child with type 1 diabetes to understand what even the 20% or whatever portion, if they have drug coverage, they're paying can add up to. But we've got to also look at this in the context of broader affordability, whether we're talking about food, all these things, and core inflation that are in the news today, housing. And if that's really the problem that we're trying to get at, I'm not sure that this particular approach is the wisest from a provincial perspective. There are just too many urgent matters in healthcare to be cutting out sources of funding that add up in the end, that add up to a big part of the access solution for Canadians.
Jay, I saw you take yourself off mute. It sounds like you're champing at the bit to respond.
You're quite right. So, I would, there's part of what Fred said that I agree with, in that, of course, there are many, many competing priorities. And I will be the first one to say that universal access to primary care is arguably our greatest need in the country right at this particular time. But the reality is, in terms of, should this be universal single payer versus a fill the gaps approach to pharmacare, at the end of the day, Canadians are paying huge amounts of money for their medications. If they either are going to get it through a universal single payer plan like this, or if they get it through their private drug plans, they're ultimately paying the price for that anyways. It's coming out of their employee benefits, or they have neither of those and they just may not be able to get the medication. The reality is that especially if one chooses wisely the kinds of things that are covered, we're actually going to save the public. We're going to save Canadians money in the long run. So, there have been critiques about why diabetes and why not high blood pressure, why birth control and why not, catastrophic drug coverage. They've picked a couple. I think they're actually not bad choices. And actually, by being able to treat diabetes up front saves enormous public cost in the end with all of the advanced things that can take place when people don't get their diabetes treated. For women to be able to get access to birth control and reproductive rights is absolutely enormous and saves not only fiscal costs, but social costs in the long run. And I actually think that this is going to prove itself. It's a bit patchwork in the way that it's being introduced. But as people walk up to that pharmacy and get their birth control pills handed over without a cost, as they walk up and get their metformin or their insulin without a cost, I think it's going to be quite impressive to see the reaction of Canadians, the reactions of their physicians who finally can see that people are going to be able to have their conditions treated, and it will speak for itself in the end.
Rosalie, let's talk a bit about some of those costs, because when pressed on the cost, Minister Holland cited $1.5 billion. Now, we spend way more than that on drugs each year. So where does the rest come from?
Well, we do spend a lot more than that. The public system actually already spends about $16 billion as of 2021. The private insurance system adds another $13.5 billion, and about $7.4 comes out of pocket. Just on diabetes drugs alone, public and private insurance covers more than $3 billion annually. So really what we see with that is the notional number of $1.5 billion is pretty unrealistic to me, unless the federal government truly expects that the provinces will shoulder the majority of the costs. Partly, I also want to point out that by being first payer, different families across the country, given that they already have different levels of support, will actually have different levels that they could potentially stand to benefit. So for diabetes specifically, provincial coverage can range from 0 to 100%, depending on age, income, the types of medications used. And so really, given that the provinces do have existing coverage in some places, I think we need transparency about exactly where that $1.5 billion number comes from, just first to make it believable. What is the plan? Because though it might lower costs over the long term, it's unrealistically low given current spending, and that diabetes has actually doubled as a proportion of spending, as a proportion of total spending for both public and private drug plans. It's a huge growing liability. And so I think we need some realism in terms of how this is going to be financed and where they think the money is going to be coming from.
Well, Jane, Fred, let's get from you your thoughts, because you've been in the hot seat. The lack of detail suggests the blanks will be filled in by negotiations with the provinces. Jane, does that concern you?
Well, those are going to be difficult negotiations, but Canadians are fed up with jurisdictional squabbling. And I think this is going to be a case where Canadians are going to expect health ministers from across the country to get together and figure this out. And, at the end of the day, most Canadians don't care who pays for their public and social services. They just want to actually have functional systems. What we have right now is not a functional system. We've got 100 different public plans. We've got 100,000 or more different private plans. And so it is really incumbent on those health ministers and their officials to get around the table and say, let's figure out a way to make this work. Let's give this our very best try to show that it works. Let's not try to sabotage one another and try to make the in the end for Canadians to be the losers, but there's got to be a way to get this done. It's a matter of shifting costs in the end. If you actually get people the care they need at the right time and the right place and the progression of their illness, we know that an ounce of prevention is worth a pound of cure. And right now we're paying a lot of pounds of cure because we're not actually being able to get the treatment that people need at the right time. So I hope that those people will roll up their sleeves, will stop trying to win political games, and will say this is about Canadians' health. There is nothing more important to the people of Canada than the health of themselves and their loved ones. So let's put in the work to figure it out, to find a way to be able to share the cost at the end. A taxpayer is a taxpayer, whether they're paying their taxes to the feds or to the provinces. Let's sort it out in a way that is going to be able to give this a try and be the country that we could be, that people have been asking us to be for decades now. And one of these days, people are going to have to collaborate around that table.
Fred?
Well, I mean, there are a number of things that Jane just said that I would completely agree with. And, if you look at our recent track record in terms of federal provincial cooperation in health, I think it leaves a fair bit to be desired. So, I would agree completely that there's a need for ministers and their departments to step up, and whether we're talking about the introduction of Pharmacare or whether we're talking about finding and connecting Canadians with family physicians who don't have one to actually coordinate their care if they have access to the drugs, or any other issue, health human resources, huge issue right now. We're just not seeing the level of cooperation and consensus that we need, in my opinion. And this, I'm speaking to you as a former provincial minister, that actually I believe that healthcare in Canada is a shared responsibility between the federal and the provincial government. Sort of literal interpretation of the Constitution is not top of mind, and I don't think it is for any health minister. But whether we're going to need some data, I think if we look at something like vaccines in Canada, there's a very high level of cooperation amongst jurisdictions. There's excellent accessibility to the vaccines at no cost for Canadians. And we do that, I think, primarily through the lens of public health, right? So that's not managing chronic disease. That's a primary prevention strategy. If that lens is applied to this proposal, and I'm just talking about the two categories that are initially funded, I think there could be some opportunity for success. But I can remember in my own department telling me on an annual basis how many tons of drugs were actually wasted or thrown away in Alberta as a result of people filling prescriptions but not actually taking the medication. Maybe in some cases not having the appropriate connection to provide primary care to guide them. I think we're going to need some data to find out whether making these available, that handover scenario that Jane describes, results in better adherence to medication and ultimately better outcomes. And we're not going to know that going into this. But so those are some things that's people want to think, and a lot of it is about the money. But it's also about how the care is organized and delivered. And, I'm not a physician, but drugs are an enabler to a better outcome. But they don't, in my experience anyway, they don't deliver the outcome all on their own.
Since Pharmacare now needs to be negotiated with the provinces that, some of them anyway, are hostile to Ottawa, will the NDP dream of a true national Pharmacare program ever become a reality? Jane?
I believe a true national universal single-payer Pharmacare program can become a reality. I think that this is a less than ideal way for it to be introduced, but given that that's what we now have to work with, I hope that politicians and public officials will roll up their sleeves, make sure that this is given the best possible opportunity for success, because this is about people's health, and that's one of the things that we expect public officials to put as a top priority.
Brett?
I don't think it will become a reality, certainly not in what's left of this political cycle. And I'm not sure, depending on what happens after the next election, whether it will advance either. I think it if we are to do it, we also have to be able to address the other urgent priorities in the healthcare system: access to medical care, recruiting, training, and retaining staff to actually deliver the care in the healthcare system. I don't think Canadians are going to allow a complete shift of focus to this issue at the expense of their governments not dealing with those other issues.
Rosalie.
I'd say I think there are a lot of priorities and the timing might be a bit strange, but I also think that Pharmacare has been on the to-do list for so long that we probably shouldn't let perfect be the enemy of the good, but there is a long and complicated road between here and anything that we could actually call a national comprehensive plan, regardless of whether it's a national, universal, federal funded, or something that fills in the gaps. Regardless of your opinion, we should make progress on this issue, but there is a long road between here and something that would actually look comprehensive to Canadians.
Thank you all for your time and insight. This has been a fascinating conversation.
Thank you.
Thanks for having us.
Rosalie Wyonch is a senior policy analyst and the leader of the Institute's Health Policy Council and Research Initiative. Fred Horne is a Canadian health policy consultant at 360 Public Affairs, an Institute senior fellow, and a former Alberta Minister of Health. And Dr. Jane Philpott is a former federal health minister. For more insight into the state of Canada's healthcare system, the future of Pharmacare, and more, visit cdhow.org. I'm Michael Hainsworth. Thanks for joining us.
You've been listening to the C.D. Howe Institute podcast with Michael Hainsworth. Subscribe on iTunes, Google Play, and Spotify. The C.D. Howe Institute is an independent, not-for-profit research institute whose mission is to raise living standards by fostering economically sound public policies. The Institute is widely considered to be Canada's most influential think tank and a trusted source of essential policy intelligence, distinguished by nonpartisan, evidence-based research and subject to definitive expert review. Visit cdhow.org and follow us on Twitter and LinkedIn. Thank you.